All right, everyone, we're going to go ahead and get started here. And I just want to say hi to everyone dropping messages in the chat. I see Jay used to work in emergency back home in the Philippines, but currently in Canada. That's exciting. I see Emmy is plugging in from Kenya. It's 2 a.m. You are committed. I love that. And then we've got friends from Virginia, Ohio, Canada. Love it. You guys are so awesome for being here today. And I want to go ahead and welcome you to our webinar on hematologic diseases. I'm really excited to dive into these disorders today. They are kind of less talked about than everything else that we usually dive into, but they're still really important NCLEX topics that we need to be aware of. They are often overlooked, but again, we need to know all the things, right? So it's important for us to talk about these. These conditions don't only affect one body system, they actually impact oxygenation, perfusion, immunity, clotting. And this means that you're actually going to see them tested in a variety of ways on the NCLEX, including prioritization, critical thinking, as well as our well-known safety-based questions. So our goal today is going to be to make these complex disorders feel clear, clinical, and NCLEX ready for you. And we are going to cover the anemias today. We're going to talk about iron deficiency anemia, pernicious anemia, and sickle cell anemia. You're going to learn to compare and contrast the pathophysiology, the causes, the interventions, different things about them. We're also going to dive into some bleeding disorders like hemophilia and DIC, which is, it stands for disseminated intravascular coagulation. And we're going to walk through some of the clotting cascades that come along with these, as well as what to do in a crisis. Now, remember, our webinar isn't teaching you all these topics from scratch, right? But we are going to be going into an overview. We're going to be going into the interventions, the pathophysiology, the clinical presentation. Again, we know that you guys already have learned these topics, but we're kind of doing an overview of what you need to know for the NCLEX on them, right? So if we were to teach them from scratch, it would take a lot more time than just a single webinar. But I want you to know that all throughout this webinar, I will be available for questions. If you need to stop me, feel free to drop a chat for me. Let me know what you need from me. Need me to go back to a previous slide? You need me to answer a question? Do you need me to kind of take it slower and explain something a little bit deeper? That's fine. We do have a time constraint, but I will try to get through all of it. This should be good for us to get through all of it. And in between slides, I will be checking in on the chat. So if you don't see me answer to you right away, you'll know that I am eventually going to get to it. But if it is urgent, you feel free to unmute and stop me and talk to me. And I will give you guys opportunities to participate, as well as a little intermission in the middle, so you guys can like use the restroom and stuff. So I've had requests about that before. So I know it's a 2-hour webinar, so we have to have a little bit of time in between to at least stretch our bodies, right? So the next topic we're going to talk about is leukemia and lymphomas. That's going to be the last one. We are going to cover types, signs, and nursing priorities. And then we're going to finish off with a block of NCLEX style questions so that you can apply what you learned today or what you kind of had a review of. And throughout the session, I will break everything down into manageable, testable parts. We are going to use some mnemonics. We're going to use, real world scenarios and next gen NCLEX tips to help you understand not just the what, but also the why. And we're also going to talk about what to look for in priority questions, like how to recognize dangerous signs, how to educate clients safely and effectively, which are all essential for passing and practice in the real clinical setting, right? So like I said, feel free to take notes, feel free to ask questions, and stay engaged. We're going to try our best to make hematology simple, memorable, and passable. So let's go ahead and get started. But before we do, I do want to let you know that this webinar is being recorded and it will be uploaded to the Naxlex website on the previous webinar section, alongside with our presentation slides, which you can download or print for future use. And if you don't know where that is, I can show you. But I'm going to go ahead and jump in. I'll just give you a very small intro about myself. I'm Maria. I'm a registered nurse. You may or may not have seen me before. If you have seen me, it may have been in a webinar about adult health or maternal newborn health, or you may have seen me answering some rationales in the test banks. And I have worked in healthcare for a while, coming up almost 10 years. And I have worked in various different areas of healthcare. I've worked in emergency care. I've done infusion nursing, like home health. I've done maternal newborn care. And I've worked in step-down ICU, acute care, so lots of different areas. I have my experience to offer you guys today. So, whatever you want to ask away. If I don't know something, I'll tell you I don't know. But for the most part, I hope I have the knowledge that is needed for you to understand all these topics. So, like I said earlier, if you want to introduce yourself in the chat, drop where you're from. Are you taking the exam for the first time? Are you transferring your license? Are you trying again, which is totally okay? And like I said, feel free to unmute, say hi, and participate, especially when I open the floor for participation, which will be towards the end when we do our questions. But before I start, welcome to our first content section, of course. I am going to start with the hematologic system overview as a whole, so we can kind of make sense of the disorders that we're going to be covering today. I want you to think of the hematologic system as kind of the body's transport and defense network. It is responsible for one of the most important things in the body, which is carrying oxygen to the tissues, including our brain, our heart, using red blood cells and hemoglobin. I'd argue that is actually the most important function in the body, because without that, we wouldn't be able to do anything. We wouldn't be able to live. The hematologic system also protects the body through white blood cells, which are the immune cells. It also stops bleeding via platelets and clotting proteins. And it regulates fluid balance and removing waste. Now, of course, a lot of these functions do cross over between systems, but just giving you an overview here of some of the main things the hematologic system is responsible for. Now, the bone marrow is actually like a factory in the body where all these cells are made through a process called hematopoiesis. And if the system does malfunction, then your client will show signs of hypoxia, of bleeding, of infection, fatigue, which are all huge red flags on the NCLEX. So I want to make sure that today you get comfortable with some lab values that the NCLEX loves to talk about, although we are not going to go over standard lab ranges, because the next gen NCLEX already has the lab ranges for you. So that's not necessarily something that we need to go over today. However, we will talk about how the labs do affect these different conditions and kind of what to look for in those numbers. I still urge you to get familiar and memorize your lab reference ranges, because that's going to help you do your critical thinking and application of knowledge a lot faster. And also it's going to help you understand the pathophysiology behind it too. One example of these lab values that I'm talking about is like, when should you be concerned? When there's low platelets, right? That would typically be if you have less than 150,000, that would equal a bleeding risk. Or if your H&H, your hemoglobin and hematocrit is too low, you would think anemia, right? Or how to interpret your INR or PTT when you're managing an anticoagulated patient. So these are all going to be important things to know about. The rest of today's presentation is going to focus on what happens when the system kind of breaks down or starts to malfunction, starting with the anemias, then the bleeding disorders, and finally the cancers of the blood. So let's jump in to our first topic here, which is the three anemias: iron deficiency, pernicious, and sickle cell. This is one of the most commonly tested hematologic conditions on the NCLEX. And anemia is not just a disease itself, it's actually a symptom of an underlying condition. And this condition results in a decrease in oxygenation in the body, the oxygen carrying capacity of the blood, actually. And usually this happens because there is deficiency, right, in red blood cells or hemoglobin. So you'll often see anemia show up in different forms in the body. Iron deficiency anemia is actually the most common type. It's usually due to blood loss or poor intake of iron. Pernicious anemia is caused by a lack of the intrinsic factors that are needed to absorb vitamin B12. And sickle cell anemia is a genetic disorder, actually, that causes red blood cells that are abnormally shaped. They're like sickle shaped, and it leads to really painful vaso-occlusion and organ damage. It is a very painful and dangerous condition. Now, the NCLEX will often test on how to distinguish between these types of anemias, which labs you need to prioritize when you're dealing with them, and also how to manage acute versus chronic complications. So we're going to walk through each of these types of anemia using the same format that I talked about, like pathophys, causes, clinical signs, diagnosis, management. And we're always going to try to connect it back to the NCLEX with priority clues, critical thinking, and patient safety. Before I start with this topic, I am going to go ahead and look at the chat here and see what else you guys are saying. I am so happy to hear that. Thank you guys so much. Awesome. Still seeing some introductions in here. Thank you guys for chiming in. I appreciate you. Beautiful. Well, let's talk about the pathophysiology of anemia. I want to go ahead and compare how each of these anemias impact red blood cell production or function in the body. So iron deficiency anemia, let's start with that one. We know that iron is a building block of hemoglobin. It's actually a key building block. And without iron, the hemoglobin can't form properly. And this actually leads to microcytic or hypochromic red blood cells. So the word microcytic actually means small. So if you hear microcytic red blood cells, that means the red blood cells are too small. Or hypochromic blood cells, which means they are pale. And oxygen delivery is reduced in iron deficiency anemia, and then the body will compensate with symptoms like fatigue or tachycardia. Those are two of the most common symptoms with iron deficiency anemia. Now with pernicious anemia, this is going to be a type of vitamin B12 deficiency, and it's usually because of a lack of intrinsic factor, which is needed for B12 absorption in the gut. So this is more of like a gut dysfunction. And without B12, the DNA synthesis will be impaired, which will lead to the production of large and immature red blood cells known as megaloblasts. So we already see a difference here, right? Iron deficiency, we have small, pale red blood cells. Whereas pernicious, we have large but immature red blood cells. And because these red blood cells are immature, they will die prematurely, which will worsen the anemia in the body. And then sickle cell anemia is actually a genetic disorder. The red blood cells in sickle cell anemia will contain abnormal hemoglobin S, which will cause the cells to sickle under low oxygen. So they kind of become like a sickle shape. And that can happen because of low oxygen, dehydration, or stress. And these sickle-shaped red blood cells are going to be really rigid, and they're going to potentially block vessels, which can lead to vaso-occlusive crises, pain, and tissue ischemia, which we know is very dangerous. So I have a little mnemonic here. It's very simple, IPS, and it's just to remember iron, pernicious, and sickle, which are the three types of anemia. So if you think about those small words like micro, mega, and shape, they will kind of remind you the pathophys of how each anemia presents in the body. Now, let's go ahead and break down the major causes and risk factors for each type of anemia from an NCLEX perspective. Iron deficiency anemia is actually going to be the most common globally, like I said. And it's usually because of blood loss, like menstruation, like GI ulcers, right? GI bleeding, chronic NSAID use. And it's also going to be from inadequate intake of iron, which can be common in populations that have poverty or malnutrition. And then it's also going to be caused by malabsorption. So maybe they do have enough intake of iron, but they may not absorb it well enough. So they could potentially have celiac disease, or they could have had bariatric surgery. Those things can definitely affect the absorption of nutrients in the body. So a little NCLEX tip for iron deficiency anemia here is you're going to think if you have like a pregnant adolescent, right? They already kind of may have a risk factor for poor nutrition from being teens, and they're pregnant, which already puts you at risk for anemia. And they're females, which puts you at another risk for anemia, right? So they're in 3 risk factor groups there. Or think about clients that have really heavy periods, right? They bleed heavily for multiple days out of each month. So they are losing a lot of blood, and that is leading to iron deficiency anemia. A lot of women have that. Or even clients that have chronic GI conditions, right? Maybe they're chronic NSAID users because they may have some kind of chronic pain disorder, or they have a chronic GI condition like liver problems with portal hypertension, or they have chronic ulcer problems like peptic ulcer disease. So those are all people that are at risk for iron deficiency anemia, and they might be some populations that may show up on the NCLEX. So be aware of those. And then when it comes to pernicious anemia, the problem here is actually going to be, like I said before, a lack of the intrinsic factor, which is essential for absorbing B12. And the causes are going to include 1, autoimmune destruction of gastric parietal cells, so some autoimmune problems, gastrectomy or ileoresection, which is where the intrinsic factor is made and used. Some vegans may have a B12 deficiency if they don't consume products that contain B12 or if they don't supplement. So some veganism populations may have a higher risk for pernicious anemia as well because B12 is only found in animal products. So the NCLEX tip here for you is to look for neurological symptoms in elderly patients with a history of GI surgery or if they've been vegan all their lives, right? So those are just some things to think about. And then for sickle cell anemia, this is going to be a genetic inherited disease. The person must receive 2 abnormal genes, 1 from each parent. So it is an autosomal recessive disorder. So ethnicity is actually going to play a huge role with sickle cell anemia here because it is most common in African descent, but also seen in Mediterranean and Middle Eastern populations. And the tip here for the NCLEX is to know that the carriers that have the sickle cell trait, they can have mild symptoms when they have extreme exercise or hypoxia. So that's something to think about as well. Now let's dive a little bit into the clinical features of each of these. All of the 3 types are going to share some common anemia symptoms like fatigue, pallor, which is like pale skin, weakness, and shortness of breath. But let's also talk about how to differentiate them on the NCLEX. So for iron deficiency anemia, you're going to have some classic symptoms like you're going to have some brittle or spoon-shaped nails, which is called koilonychia. It's a funny word. And these patients may also crave substances that are non-nutritive like ice or dirt. This is actually called pica. It's when you have a craving for non-food items that may indicate that you have some kind of a nutrition deficiency. And this is also an NCLEX favorite topic, so remember this one. Now, these patients may also have tachycardia because of compensation for the low oxygen carrying capacity of the body, so of the red blood cells. Now, iron deficient patients may look pale and tired, especially postpartum moms and young women that have very heavy periods. And those things combined may point towards iron deficiency anemia. Now, when it comes to pernicious anemia, again, we talked about how it's caused by B12 deficiency. So here, you're going to expect some neurological symptoms like numbness and tingling in the hands and feet, which are called paresthesias, like ataxia, which is a loss of coordination. So maybe like very clumsy, right? Glossitis, which is when a client has a very smooth, beefy red tongue. Confusion or memory changes, and also fatigue, pallor, and possibly jaundice because of the breakdown of the red blood cells. So when you're seeing anemia symptoms and neurological symptoms, think pernicious anemia. You're going to think B12, right? And then for sickle cell anemia, this is going to be a chronic and systemic condition. And some of the hallmark signs are going to be vaso-occlusive crises, which is when clients have severe pain from their vessels being blocked. Dactylitis, which is hand and foot swelling in infants. So infants can have sickle cell anemia, of course, because it is a genetic disorder, so they'd be born with it. Priapism is a sign of sickle cell anemia, and that's when somebody has a very painful and prolonged erection that lasts hours at a time. Splenomegaly and the risk of infection, so compromised immune system. And then some of the triggers for sickle cell anemia or for the crises that these clients experience are going to include cold temperatures, stress, dehydration, infections, or anything that's kind of messing and with the immune system and causing an immune response, and also very high altitudes. So remember, an NCLEX tip here for you is that in a crisis of sickle cell, pain is going to be the priority because it is such a painful condition for clients. So you're always going to address pain first before anything else if somebody's having a sickle cell crisis. Now I have a few little mnemonics here for you. IDA, which is iron deficiency anemia. This one is I'm pale and tired plus pica. So it's talking about pallor, it's talking about fatigue as the symptoms, and it's talking about pica, which is that craving for non-food items that may contain, that may kind of indicate that they have a deficiency. Then we have PA for pernicious anemia, and that would just be BA for B12, or I'm sorry, B for B12 plus brain symptoms. So the B, right? The B reminds you of B12 and brain, which are the neurological symptoms. And then we have SCA for sickle cell anemia, which is sickle cells cause swelling, spleen issues, and severe pain. So we have the S's in there, right? So it's going to be swelling, spleen, and severe pain. So, like I talked about with iron deficiency anemia, talking about the mnemonics here, I'm pale and tired. These are the hallmark general symptoms of anemia, right? But especially common in the iron deficiency anemia. Pale is because of the decreased hemoglobin. And tired is because of the reduced oxygen delivery to the tissues. And again, like I talked about, pica is that unique NCLEX worthy clue here because it refers to cravings for non-food items that are strongly linked to iron deficiency. And those items would be like ice, dirt, paper, like really random weird things. And if a question in the NCLEX mentions a woman that is craving ice or dirt and is also having fatigue and pallor, you're always going to think iron deficiency anemia. Now, explaining the second mnemonic here, PA, B for B12 brain symptoms. Of course, this is a B12 deficiency anemia, like we talked about. And then the brain symptoms are because pernicious anemia is the only one out of all three that has neurologic manifestations because the B12 vitamin is actually essential for the myelin sheath maintenance in the brain and the nervous system. So like I said, there's going to be memory issues. There's going to be paresthesias, which like I said is the numbness and tingling, the ataxia, the loss of coordination, confusion, mood changes even. So if you see signs of anemia plus neurological changes, you're going to immediately consider pernicious anemia. Now, the third mnemonic here is going to talk about sickled cells, which are the core of this condition, right? We know that the red blood cells are going to be abnormally shaped in the kind of a shape of a moon. Becoming really sticky and then clogging up vessels that are small. And we're going to have swelling of the hands and feet, which is that dactylitis. And this is going to take place in infants, not adults. And then we're going to have spleen issues because the spleen is going to get damaged from those sickling episodes happening repeatedly. And that's going to lead to functional asplenia and high risk for infections because the spleen is involved in our immune system. And of course, last but not least, we're going to have severe pain because of the vaso-occlusive crises, which is one of the most common reasons that patients are hospitalized with the sickle cell crisis. Now I want you to remember, I'm going to repeat this one. Remember that pain is always the number one priority with sickle cell crisis, and you're going to treat that pain first and fast. And then afterwards, you're going to think hydration, oxygen, and of course, pain meds, right? Let me chime in here into the chat to see if you guys are asking anything. What is pica? So yeah, pica actually means non-food cravings. You're right. Thank you for answering that. So it's just a weird word. It's not like the letters are abbreviating any specific words. It just means it's a craving for any item that's non-food and that has no nutritional value, but it actually signals that that person is suffering from some kind of a deficiency, usually an iron deficiency. So I'm going to go ahead and dive into how we're going to identify each of these types of anemias on labs. This is going to be prime NCLEX material here, of course, because it's the application of our knowledge, right, to recognizing conditions. So first, let's go into iron deficiency anemia. This is going to be, again, the most common anemia worldwide. And some of the key lab values here are going to be low H&H, right? Hemoglobin, hematocrit that are lower than normal are going to be confirming anemia. And then a low MCV, I'm sure you've seen that lab value, MCV, and you're like, what the heck is MCV? Like, is it even important? It's just kind of one of those lab values that gets brushed aside. But actually, the MCV is going to tell you if the red cells are going to be microcytic, which is small, or macrocytic, which is large. And I'll talk a little bit more about that. And then, of course, low ferritin, which is going to be the most indicator of iron deficiency. Ferritin is actually stored iron in the body. So if you get a patient that has fatigue, pallor, and then they're suffering from low ferritin and low H&H, this is a classic presentation of iron deficiency anemia, or IDA. Now, jumping into the pernicious anemia here, the labs are going to show a macrocytic anemia. So the MCV is actually going to be high because the red blood cells are large, if you guys remember me telling you that at first. Of course, the serum vitamin B12 is going to be low. So if the labs do show a vitamin B12, it's going to be low for that. But for confirmation, we are going to look for positive intrinsic factor antibodies. This is actually what makes it a pernicious or autoimmune type of anemia. And then jumping into sickle cell here, this is going to be suspected in patients of African descent, or like I said, Mediterranean or Middle Eastern, and as well as if they're having symptoms of anemia, as well as if they're having pain crises, right? So it's not just going to be one or the other, it's going to be a combination of those factors. So the sickle cell test is actually going to be a screening tool, and they are going to do a hemoglobin electrophoresis. This is going to confirm the diagnosis by detecting hemoglobin S, which is an abnormal hemoglobin. Now, an NCLEX clue here is if you're given a chart or a case study with labs, I want you to look at the MCV to narrow down if it's microcytic or macrocytic anemia. And if there's pain plus anemia plus African descent, you're going to think sickle cell until proven otherwise. Now let's dive a little bit into kind of a side quest here, talking about MCV, right? This very underrated, unheard of lab that we don't really think about that much. We see it and we're like, okay, whatever. What does that even mean? Well, MCV actually stands for mean corpuscular volume, and it actually tells us the average size of our red blood cells on a CBC lab, which is called CBC complete blood count, right? So a normal MCV is going to be 80 to 100 femtoliters. And a low MCV, which is less than 80, is going to mean that our RBCs are smaller than normal, RBCs for red blood cells, and that's actually called microcytic. If the MCV is higher than 100, then our RBCs are macrocytic, which means they're larger than normal. Now let's talk about microcytic versus macrocytic anemia. If a question includes low MCV and fatigue and pica, you're going to think iron deficiency. But if a question is telling you they have a high MCV, numbness and tingling, which is a neurological sign, then you're going to think pernicious anemia, right? So that's kind of a little tiny side journey into the MCV there. It may not be, in every question about anemia, but if it is, now you know. And let's talk about some common questions that may come up as we talk about these topics here, like what lab value is most specific for iron deficiency. And that's going to be ferritin, which shows the stored iron in the body. Which anemia shows macrocytic RBCs on the CBC lab, and that's going to be pernicious anemia, right? Pernicious has large cells that are immature and iron deficiency is going to have small cells that are pale. Now, which test confirms sickle cell disease? That's going to be that hemoglobin electrophoresis. A client with fatigue, a smooth red tongue, and tingling hands, which test would you do next? And that would be a vitamin B12 level, because those are classic signs of pernicious anemia. And then what is the MCV in iron deficiency anemia? And that's going to be decreased, or also known as microcytic. So they're small. All right. Now that we're done with our first topic, let me jump in here and see if you guys have any questions.
I just have one question.
Yeah.
With pernicious anemia, are they in pain too? Like would it?
No. Sorry, go ahead.
Are pernicious anemia patients in pain like sickle cell? Like how sickle cell priority is pain, what is pernicious anemia's priority? To just replace the vitamin B?
Yeah, so basically, that's a great question. Basically, patients that have the sickle cell anemia, they're going to be in a lot of pain because they're having vaso-occlusive crises where their cells are being blocked up by these sickle-shaped cells. So they are going to have pain, but people with pernicious anemia are actually going to have more so paresthesias. So more of those neurological symptoms where we have what do you call it, neurological symptoms that are appearing in the body. So if we're having like memory problems, confusion, we're having the numbness and tingling of the hands and feet, those are going to be more common with the pernicious anemia. So not necessarily pain, but the pain that does come with the sickle cell is going to be really intense for these patients. So yeah, that was a very, very good question. I appreciate you asking that. Anything else I can answer for you guys?
Hello. I got a question about prioritization,
Yeah.
but not about the anemias. More like about which diseases should I prioritize over sickle cell disease?
What are the priorities for sickle cell disease?
No. Which diseases, which illness should I prioritize above sickle cell disease?
Okay, so are you talking about the anemias? Like if you had a patient with pernicious anemia, a patient with iron deficiency anemia, and a patient with sickle cell disease or sickle cell
No,
anemia, which,
no. If I'm talking about if I'm having a patient with a vaso-occlusive crisis,
uh-huh.
which is very dangerous,
Yeah.
versus other diseases different from anemia.
Okay.
Which one should I prioritize? Because I've been doing question and I always go for vaso-occlusive crisis, but
Yeah.
it's the wrong answer versus those diseases.
Yeah. It depends what the disease is. So like let's say for example, you're having somebody with a DIC, right? The disseminated intravascular coagulation. They're having a DIC versus you're having somebody with pernicious, or I'm sorry, with sickle cell crisis. You would definitely prioritize that person with disseminated intravascular coagulation because they're going to be in a life-threatening situation. Like, and we're going to talk about that condition later too, where they are bleeding from like every orifice in the body and having like abnormal clotting all at the same time. So that's definitely going to be priority over the sickle cell crisis. Now, it really depends what disease you're talking about, right? If that disease has some kind of a circulation problem where they're at risk for blood loss or where they're at risk for low perfusion to the brain, or if they're having like an airway compromise, you would definitely prioritize those first. With the vaso-occlusive crisis, what you are prioritizing is going to be the pain management. Is the first thing that you're going to do is pain management and then oxygen and hydration. But yeah, if you're having another disease that's putting that patient at a higher risk of their life being threatened or of them having like a fatal outcome in the situation, then you will prioritize those above sickle cell. But if you can give me an example of one of the questions that you saw, I will definitely explain it for you.
I did one about I had the option of vaso-occlusive and also postpartum hemorrhage, which
Oh,
can lead
okay.
to the, as you say, it could lead to DIC.
Yeah, exactly. So the postpartum hemorrhage is definitely going to be number one, above the sickle cell crisis. And that's actually a really good question because they're both, really serious problems. But the postpartum hemorrhage would definitely come first. And the reason why is because it can happen so quickly. It can lead to hypovolemic shock or hemorrhagic shock. So that mom is at risk of dying within like a very short time. And as you mentioned, DIC as well, which is also very dangerous. So definitely would prioritize postpartum hemorrhage over the sickle cell.
Do you
Thank
do
you.
you have Professor, do you have another anemia called aplastic anemia?
Do you have another what?
Anemia that called aplastic anemia.
Oh, aplastic anemia.
Yes.
Yes, there is something called aplastic anemia. We didn't talk about that one today. There are some more rare types of anemia. The ones that we talked about today were the most common ones that we find on the NCLEX. But aplastic anemia is when the bone marrow fails to produce enough red blood cells. Because as we know,
decreased electrolytes. Okay.
exactly, because the bone marrow is responsible for producing our RBC. So when it doesn't produce enough, then that's when we have aplastic anemia. But yeah, we didn't talk about that one today. I don't know if we may have another webinar because we kind of break up the topics so it's not like too much at once. But I don't know if we're going to be talking about that one. We might be in another one, but yeah, that's a really good point that you brought up. There are lots of other types of anemia too. These are just going to be the primary ones.
Okay, thank you.
You're welcome. Thank you guys for your questions. Those were excellent questions. I really appreciate that. All right. Let's see here. So the next topic we're going to talk about is going to be bleeding disorders like hemophilia and DIC. Like we talked about, DIC is a really, really scary condition that can deteriorate your patient very quickly. So I want you to understand that these two are actually extreme forms of coagulation. Hemophilia is going to happen because of a genetic clotting factor deficiency, and DIC is going to happen where there is clotting and bleeding simultaneously. Both of these can cause life-threatening hemorrhage, so that is something that is very dangerous for your patients if you don't act quickly enough. But before I jump into that, I want to go into, give me a second here. I see somebody saying, I'll be back. Please let me in shortly. Uh-oh, looks like you guys. I am so sorry about that. Looks like we had a short tech problem here where my meeting just disconnected. I hope you guys are all still here. I still see the same number of participants. My sincere apologies. We have tech issues happen sometimes. Please forgive me for that, but I am back. Sorry about that. So let's talk, before we jump into the next topic here, let me go ahead and share my screen with you guys again. Sometimes we have little tech issues, but I'm glad that things worked out where I'm back here with you guys. All right. So before I jump into the bleeding disorders, I just want to tell you some major interventions that we are going to use for iron deficiency and for all the different types of anemia. For iron deficiency anemia, we are going to have our patients have iron supplementation. We can give them PO iron sulfate, or we can give them IV iron infusions for severe cases. We always want them to take their oral iron on an empty stomach if they're able to tolerate it, and if possible with vitamin C, because it does increase the absorption of iron. We're also going to encourage some dietary changes, like for them to possibly include some iron-rich foods into their meals, like red meats. If they are vegan, they can have dark leafy greens, fortified cereals, and beans. We are also going to talk to them about preventing constipation, because iron can cause constipation. So they are going to increase their fiber and fluids. And then we're also going to monitor their labs frequently to make sure that their iron is being absorbed appropriately. So we are going to look at hemoglobin and hematocrit and reticulocyte count in order to assess the response of the iron supplementation. And if they are taking iron supplements, a normal side effect is to have dark green or black stools. So that is something that is important for us to learn to differentiate, right? Sometimes we have dark stools when we are having GI bleeds, but if they are taking iron supplements, those dark stools are most likely actually from the iron supplement. And we also want them to take their iron supplements away from calcium, because calcium does block the absorption. And of course, they're going to continue their therapy for at least a couple of months after their labs normalize, just to make sure that we're replenishing their iron stores. And then when it comes to pernicious anemia, we can offer lifelong intramuscular injections that can happen monthly, or a really high dose oral B12 if they are having good GI absorption and no malabsorption issues. But we are always going to monitor for neurological status when they are having B12 supplementation, like paresthesias, like I talked about, that's numbness and tingling, balance issues.
Excuse me, Maria, can we see the note for those? Do you have a
Yeah,
note on those?
absolutely. I'm going to re-upload my presentation here, because it looks like this one is missing my slide on the management of it. So for some reason it didn't pop up here, but I am going to upload it into the chat for you guys so you guys can have it. My apologies.
Okay.
And then we are going to encourage dietary B12 sources too, like animal proteins, eggs, dairy, and fortified cereals. And of course, we are going to give them early treatment so that we can prevent any kind of neurological damage that could be permanent. The treatment for pernicious anemia is going to be lifelong. This is not a temporary condition. It's actually going to be something that they manage throughout their whole lives. But the good thing about it is that their energy levels will improve after several weeks of therapy. So they can, live a normal life and have normal moments without those symptoms, as long as they are continuing their B12 therapy. And as far as sickle cell anemia, we are going to go ahead and intervene, of course, with pain management. Opioids are going to be first line if they are having a vaso-occlusive crisis. Hydration, we are going to give IV fluids, because we want to reduce the viscosity of the blood, so the blood can get really thick. So when we rehydrate them, we are going to reduce the viscosity. And then oxygen therapy is going to prevent and treat the hypoxia that's caused by the sickling of the cells. So we want to keep their SpO2 at 94% or higher. And then we're going to give them prophylactic antibiotics, especially for children, to prevent infections, because as we know, infections can cause vaso-occlusive crisis, as well as make sure that they are on top of their vaccines. And then last but not least, we do want to make sure that they are resting and that we are preventing DVTs. So if we can give anticoagulation, if it is indicated, then we want to do that in order to prevent clots. We also want them to avoid certain triggers like exposure to cold, dehydration, stress, and high altitudes, which are the biggest triggers of vaso-occlusive crises. And we are going to make sure that they are hydrated. Even if they're feeling well, they need to drink plenty of fluids every day. And we're also going to encourage for them to have their routine checkups and early treatment if they are having fevers or any signs of infection. And again, I will upload the updated presentation to you guys here. I don't know what happens sometimes. There's like little issues, but for some reason the wrong presentation got uploaded for you guys. So I'm going to upload it into the chat so you guys can all download it, and I'll go ahead and show you that updated slide too. But let's go back to our bleeding disorders real quick here. And then after this topic, I want to go ahead and give you guys a little intermission. You can have a 5-minute break. So I'm only going to take about the next 10 to 15 minutes to talk about this topic. And then I'll give you a break to use the restroom, get some water, get a snack, whatever you guys need. So as we talked about, hemophilia is a genetic clotting factor deficiency, whereas DIC is when clotting and bleeding is happening simultaneously. They can both cause life-threatening hemorrhages. And a tip for the NCLEX here is that I want you to watch for bleeding signs as well as lab value changes and know when to prioritize. Now, these topics are going to be tested often on the NCLEX as well because they both require really immediate nursing interventions, but both for very different reasons. Because hemophilia is a genetic disorder where the body is lacking essential clotting factors, and DIC is like a catastrophic event where the body just forms clots everywhere, then runs out of clotting factors and bleeds excessively. Again, these can both turn into life-threatening emergencies very quickly. So we are going to have to intervene fast. For the pathophysiology here, hemophilia is passed from mother to son, so it's an X-linked recessive disease. And we have hemophilia A and factor 9, which equals hemophilia B. So there's two different types. And then DIC is always going to be secondary to something. So if the patient is experiencing sepsis, if they're having a severe trauma event, if there is an OB emergency, like we talked about earlier with postpartum hemorrhaging, like if we have a placental abruption, that's going to put them at risk for DIC. Or even if the patient has cancer, they can develop, unfortunately, this serious complication. And it is going to start with clotting of the blood, and then it's going to end with uncontrollable bleeding from every orifice. This duality is going to be key for you to remember on NCLEX questions. And I want you to remember this little mnemonic for the DIC, and it's going to be the death is coming, DIC. And that means that it has a very fast progression and that we need very fast intervention. Otherwise, it could lead to death. So the clinical presentation of hemophilia here is going to be very localized, and that's kind of
excuse me. Can you go back to the next page?
Yeah, absolutely. Do you have any question I can answer for you about this?
No, I was just looking at something. Okay, thanks. You can go.
Oh, okay. Yeah, no worries. Thanks for asking. So hemophilia here is going to be localized, like I said, and that's going to be kind of your very key difference when you see it on the NCLEX. Hemophilia is localized, DIC is systemic and very rapid. So with hemophilia, I want you to think surgical sites, joints, the gums even. These clients are going to appear stable until they have trauma, and then they'll start to bleed uncontrollably. And then DIC is going to be systemic and rapid. You're going to expect bleeding from all orifices, like I said, oozing from the IV, signs of shock. It's going to be a very, very dramatic presentation. Both of these disorders are going to need very close monitoring. However, DIC is actually going to require ICU level care and very, very fast diagnostics. Like I said, it can lead to organ failure, hypotension, shock, and death. And the way that DIC is going to present is going to have some petechiae. So there may be like kind of these like purple spots all over the body and bruising. And it kind of looks like bruising, sort of like this previous slide here. And they will have bleeding from every orifice. So they may have like bleeding out of their nose. They may have their IV sites oozing with blood. Their gums might start bleeding. Their wounds might start bleeding. So you're really going to see a lot of blood with DIC. Whereas with hemophilia, if they had some trauma, let's say they had, a procedure and they had a surgical procedure to close like a wound or something, you're going to see prolonged bleeding from that specific localized area. So like I said, the tip here for the NCLEX is that in hemophilia, bleeding is isolated, and in DIC, it's everywhere. So that's how you'll be able to recognize it if you see a case study on the NCLEX. I have a little table here of some differences when you are diagnosing both of these. As we know in the NCLEX, sometimes, even though we're not physicians and we don't diagnose diseases officially on the NCLEX, we do have questions where it's like, what's the most likely diagnostic, right? And that's what's going to guide your interventions, your management, your treatments, your medications that you're going to use, all of that. So with hemophilia, you're going to have an increased APTT, but you're going to have a normal PT and INR in platelets. Whereas in DIC, all the labs are going to be off. You're going to have a prolonged PT and APTT. You're going to have decreased platelets, decreased fibrinogen, which we know is a clotting factor, and increased D-dimer. So all the labs are going to be kind of off with the DIC. The D-dimer is actually going to be a key indicator that the body is breaking down clots, which is actually a critical clue for DIC on the NCLEX. Now, I do have a little mnemonic for you here for DIC labs, and that's going to be the platelets fell. And what it means is that you have those decreased platelets and fibrinogen, whereas you have increased PT and APTT and a D-dimer. And talking about management here, what we're going to do for hemophilia is we're going to focus on prevention and factor replacement. So the patients with hemophilia here, they may actually self-infuse at home. We want them to use soft toothbrushes in order to prevent gum bleeding. We want them to avoid contact sports that can put them at risk of trauma. And we also want them to manage bleeding with the mnemonic RICE. And I'm going to talk about that with you in a minute here. And then for DIC, we want to first treat the cause, right? Like what caused the vaso-occlusive crisis? For example, if this patient is septic, we're going to give them antibiotics and treat that cause, and then go ahead and manage the symptoms that are coming along with it. We're also going to replace what is lost. So if we need clotting factors, we're going to give them some plasma, right? If they're having thrombocytopenia, we are going to give them platelets. If they're having low fibrinogen, we're going to give them cryoprecipitate. This is going to be very time sensitive and life-saving because, again, DIC happens very fast. Now, I want to go back and talk a little bit about both of these and expand on the management for you because this is going to be the most important part of being familiar with these conditions on the NCLEX is knowing how to manage them and knowing our interventions, right? So just to remind you here, you remember that hemophilia is a genetic bleeding disorder. It is caused by deficiency in clotting factors, specifically factor 8, which is hemophilia A, or factor 9, which is hemophilia B. It is going to be X-linked recessive, which means it most commonly affects males. So it's given from mom to son. And again, mothers are going to be the carriers usually of this condition. And the primary focus in hemophilia is going to be to prevent bleeding and then to promptly replace the missing clotting factors. So like I told you before, some patients may learn to self-administer their factor infusions at home. This does allow them to manage little minor bleeds quickly and independently rather than having to have an ER visit for every little bleed. So we're going to focus our education on prevention strategies, right? So that we don't have to remedy the problem. So first we focus on educating for prevention. And then of course, if it does happen, we're going to replace those missing factors. But our education on prevention is going to include, like mentioned before, using soft toothbrushes. If they are shaving, shaving their legs or they're shaving their face or their armpits, wherever, we're going to encourage them to use electric razors rather than bladed razors because any sharp objects are going to put them at risk of bleeding prolonged and severely. And we're also going to educate them on avoiding contact sports or any high-risk activities that could lead to injury. So if they're doing like a very strenuous, scary kind of hike, right, we're going to be like, that may not be such a good idea. We're also going to monitor them for really early signs of bleeding. So if they're having joint pain, that could signal that they're having bleeding. If they're having swelling and bruising, that may signal that too. So if they are having a bleeding episode, we're going to talk about the mnemonic RICE, right? You've probably heard this on like physical therapy. R is going to stand for rest, and that's because rest is going to help reduce the trauma and allow time for clotting. I is going to stand for ice, which is going to cause vasoconstriction, and it's going to slow the bleeding. C is going to stand for compression, but only if appropriate. You are going to avoid excessive pressure because, if you are compressing with excessive pressure, that could lead to hypoperfusion of the tissue. And then, of course, E stands for elevation. That's going to help decrease the swelling and the bleeding. So let's say they had a cut on the ankle from shaving. We are going to, let them know, please rest. Please put ice on it. If you can, put a little bit of compression to stop the bleeding, right? We're not going to do any tourniquets or anything like that, but a little bit of compression would be good. And then, of course, we're going to elevate the leg, right, in order to reduce swelling and bleeding. Now remember, an NCLEX tip here is do not give NSAIDs or aspirin for pain in patients with hemophilia because these are going to worsen bleeding. You are going to use acetaminophen instead. So if you have a question about a patient with hemophilia that's feeling pain in their joints because they're having some bleeding, you're not going to give them ibuprofen. You're not going to give them aspirin. You're going to give them acetaminophen. And then, of course, as far as labs to expect, we kind of talked about this a little bit. We're going to have a prolonged APTT, but a normal PT and platelets with hemophilia, since the problem is with actually the specific clotting factors, not the platelets. Now let's jump into the final note about DIC here. We know that it stands for disseminated intravascular coagulation, and it is a life-threatening acquired condition where the body goes into overdrive with clotting, uses up all the clotting factors and platelets, and then leads to uncontrolled bleeding because all the clotting factors and platelets got used up. So the triggers here, I'm going to repeat them for you just to get them nice and branded in your brain. Sepsis, trauma, HELLP syndrome, or cancer. These are going to lead to systemic activation of clotting, increased formation of the microthrombi, and then tissue ischemia. Eventually, their clotting factors and platelets are going to get all used up, and then it's going to result in widespread bleeding and organ dysfunction, of course, because of hypoperfusion. Again, this is going to be a serious life-threatening emergency, and the key is going to be to treat the underlying cause. So like I said before, if, for example, this person has sepsis and that was the trigger, we're going to initiate broad-spectrum antibiotic IV immediately, right? IV, because it's going to be administered a lot more quickly than oral antibiotics. Now, if it's related to placental abruption or trauma, we're going to stabilize the cause surgically or medically, and then go ahead and deal with the rest, which is going to be to replace what's lost. If they lost their clotting factors, we're going to give them FFPs, fresh frozen plasma. If they're having thrombocytopenia, we're going to give them platelets. And if they are having a lack of fibrinogens, we're going to give them cryoprecipitates. And then, of course, I want to remind you of the lab findings here with DIC, which is going to be decreased platelets, decreased fibrinogen, increased PT and APTT, and increased D-dimer, which is because of the fibrin breakdown. I want you to assess for these symptoms. And if you find these symptoms, I want you to report them immediately to the physician, which is going to be oozing from the IV or surgical sites, petechiae or ecchymosis, so that weird bruising or purple spotting in the body, hematuria or hematemesis, right? Are they peeing or vomiting blood? Confusion or decreased level of consciousness, which is going to suggest that there's possible bleeding in the brain. And of course, hypotension and tachycardia, which are signs of hemorrhagic shock. And I want you to remember a little alert for the NCLEX here is that DIC will appear as a secondary diagnosis very often. So I want you to recognize it with a patient that has sepsis or trauma, and then they start bleeding unexpectedly, right? So again, secondary to these other problems that happen first. Now let me ask you some questions and answers, and then we'll go on our little 5-minute break here. Like, what is the classic lab abnormality in hemophilia A? And that's going to be prolonged APTT with a normal PT and INR and platelet count. A patient has petechiae, oozing from IV sites, and a high D-dimer. What do you suspect? Disseminated intravascular coagulation. What's the first nursing action for a hemophilia patient with joint swelling? And that's going to be apply ice and elevate the joint. Remember that rice mnemonic here. Which medication is contraindicated in hemophilia is going to be aspirin because it's going to be a blood thinner. It's going to increase the bleeding. And what labs do you monitor during DSC management? That's going to be platelets, PT, APTT, fibrinogen, and D-dimer. So that was a lot of content. Let's go ahead and take a 5-minute brain break. Stand up out of your chair and give yourself a big stretch and get yourself some more water or coffee. And I'm going to come back here with uploading that updated presentation to the chat that I didn't give you guys that one slide. It's so silly when those things happen, but I'm going to get that to you guys here. And like I said, take 5 minutes and we will be right back to talk about blood cancers, leukemia, lymphomas, and do our application questions. All right, everyone, let's go ahead and get back into our presentation here. I'm going to share my screen with you again. I hope you guys were able to get a nice little break.
I have a question.
Yeah.
Can you repeat the rice for me?
Sure, I'd be happy to. So rice is actually a very commonly used mnemonic when it comes to therapeutic ways to manage an injury. You'll hear it a lot in like physical therapy, or if somebody like injures themselves, like if they, strain a muscle, or let's say they twist their ankle or something like that. But it is going to be really useful in patients that do suffer from hemophilia. So it's going to include rest. So the R stands for rest. So them resting is going to allow them to build clotting factors, and it's going to allow their bodies to have some time to recover. Ice is going to allow to slow down the bleeding, and it's going to help with inflammation and pain. C is going to be compress. So like if you are compression, so if you compress to stop the bleeding, as well as like, let's say if you're, if this was talking about like a physical therapy aspect of it, then we would be talking about putting like compression on the joint, right? Like we would wrap it up with something. But of course, this is going to be paying mind to the fact that we want to make sure that that tissue is still intact and receiving perfusion. So if we are putting compression, it's turning purple, we know that it's lacking perfusion. We don't want to do that. And then E is going to stand for elevation. So that is going to reduce bleeding and swelling. So again, rest, ice, compression, and elevation.
I just got one more
Thank you.
question. So with hemophilia, you said that the mother transmitted to the son.
Can you say that again? I'm sorry, you were cutting out a little bit.
With hemophilia, you said that the mother transmits it to the son.
Yes, that is the most common. It's when the mother transmits it to the son. Correct.
Got it.
And then DIC would be a secondary complication of some kind of other traumatic reaction in the body, like trauma, childbirth, sepsis, things like that. I know these are kind of like weird conditions that we don't talk about enough. So I'm glad that we're going over them today for you guys. And then let me go ahead and get started here on our next topic, which is going to be the blood cancers. So I'm going to go ahead and jump in there. Let me get it here for you guys. Leukemias and lymphomas. These are going to be cancers of the blood and the lymph. So leukemia is going to be a cancer of the white blood cells in the bone marrow. And lymphoma is going to be a cancer of the lymphatic tissue. These are going to disrupt immune function, oxygen delivery, as well as clotting. And a little mnemonic that you can kind of remember here is lymph equals lymph nodes, right, from lymphomas. And then leukemia, when you see the initials of the word leuc, that means leukocytes. So that's kind of a little way to remember what each of them kind of like where each of them takes place. So this section, we're going to explore two major types of these hematologic malignancies, leukemia and lymphomas. Leukemia, which originates in the bone marrow and affects the white blood cells, and then lymphoma, which arises in the lymphatic tissues. Both are very serious. Both are going to be life-altering conditions that disrupt immunity in the body, that disrupt blood production and tissue oxygenation. And when you are taking the next-gen NCLEX, you may be asked to distinguish between acute versus chronic leukemia, Hodgkin versus non-Hodgkin's lymphoma, or even to recognize complications like tumor lysis syndrome. So let's go ahead and break this down together. Now, leukemias are going to be classified by cell type. We are going to have lymphoid versus myeloid. And then we're also going to have acute versus chronic. So acute is going to happen sudden and fast, and chronic is going to take place a lot slower in the body. And then lymphomas are going to be cancers of the lymph nodes. Hodgkin's is going to be marked by something called Reed-Sternberg cells, and non-Hodgkin's is going to be a more diverse group of lymphomas. They are going to be more common in adults, and they're also going to have many subtypes. Let's do a little overview of leukemia first. It is a cancer of the blood-forming tissues. It is going to include the blood marrow and the blood, like I said, white blood cells. It does lead to the uncontrolled production of immature or abnormal white blood cells. And these are going to crowd out the healthy cells, which are going to affect immunity, oxygenation. It's going to affect the red blood cells, and it's going to affect clotting via the platelets. And then the classification, I want you to think about leukemia as being classified based on the cell line. So first, lymphoid is going to affect the lymphocytes, and then myeloid is actually going to affect the granulocytes, the red blood cells, and the platelets. And then, of course, we talked a little bit about the speed of progression, which acute is going to be a sudden onset. It's going to have a really rapid growth of immature blast cells. And then chronic is going to be slower growing, and it's going to have more mature white blood cells, but they're going to be dysfunctional. And an NCLEX tip that I want you to know here is going to be that acute lymphocytic leukemia, which we also call ALL, is going to be more common in children. And then CLL, which is chronic lymphocytic leukemia, and CML, which is chronic myeloid leukemia, are going to be more common in older adults. So CLL and CML, older adults, ALL in more in children. And some, yeah.
Professor, what is Philadelphia chromosome?
So a Philadelphia chromosome is going to be something that's going to be associated with the genetics of chronic myeloid leukemia. And likely you're not going to be asked about this on the NCLEX, but it's kind of more of just the pathophysiology of how it comes to be. I just want you to be familiar with the different types. But the Philadelphia chromosome is going to be like a genetic abnormality, basically. It is associated with a couple of types of leukemia, with the chronic myeloid as well as with the acute lymphoblastic leukemia in some cases, not in all of them. But this goes a little bit deeper into like genetics, which is like more of like a complicated topic. If you're definitely welcome to kind of dive into it more on your own. But a little bit just to know generally about the Philadelphia chromosome is that it's found in the bone marrow. Again, leukemia is taking place in the bone marrow. But people who have the chronic myelogenous leukemia are going to have the Philadelphia chromosome in the blood marrow. So that's what it's basically going to be associated with. So if you do see that name on the NCLEX, you're going to know that that's associated with the CML type of leukemia.
Thank you.
Thank you for asking. I appreciate that. I know there's so many like unique genetic things about these blood cancers that sometimes it can be too much, but just knowing the specific NCLEX information is important. But sometimes I like to take side quests and kind of like dive deeper into what all of these mean too, because it's really, really interesting. So some clinical manifestations, and we are going to talk about manifestations later, but I want to just kind of do a little short jump into it, is because with leukemia, because of the crowding of normal cells, so they're going to be crowded out by those abnormal white blood cells. You are going to have anemia as a symptom. So like fatigue, pale skin. You are going to have thrombocytopenia, like bleeding, bruising, and petechiae, which is the little purple spots. And then you are going to have neutropenia, which is, again, a dysfunction of the immune system. You're going to have frequent infections and fevers. And some other signs may also include bone pain, especially in the sternum or in the long bones like the femur, weight loss, enlarged lymph nodes, or an enlarged spleen, and then elevated or decreased white blood cell count. And then I want to do kind of like a little bit of a jump into also some of the diagnostic tests. We are going to go into that as well. But just to kind of get you primed for the information that we're going to talk about, that if you do run a CBC with differential, so if you see like CBC with diff, with leukemia, you'd be seeing abnormal white blood cells, low platelets. If they do a bone marrow biopsy, that is something that can confirm the diagnosis. And then there's a test called the flow cytometry, and that is a test that can actually help to classify the type of leukemia that this person is suffering from. And of course, the interventions would be chemotherapy, bone marrow transplant, stem cell transplant. These all come with their own range of side effects as well. And then, of course, we want these patients to be on neutropenic precautions. Like we want to make sure we're hand washing, we're avoiding flowers, raw foods, we're wearing masks. And then talking a little bit about lymphomas here, like I said before, lymphomas are a cancer of the lymphatic system. They are going to affect the lymph nodes, the spleen, and the lymphatic tissues. They do arise because of mature lymphocytes, not because of immature blast cells like in leukemia. So that's kind of a main difference there. And we do have those two main types that are listed there. We have the Hodgkin's lymphoma, which are defined by the presence of Reed-Sternberg cells. Now, these cells are going to be really large and abnormal B cells, and they can be seen when a biopsy is done. And they are more common in young adults and adolescents, the Hodgkin's lymphoma. And they do start in the cervical lymph nodes and spread usually from node to node. They do have a good prognosis with treatment for Hodgkin's lymphoma, and the treatment is going to be similar. We're going to have chemotherapy, radiation if it's localized, and we're also going to monitor for long-term risks like secondary cancers or infertilities. And then with the non-Hodgkin's lymphoma, which this one is caused by a broad group of B cell or T cell lymphomas. There's going to be lots of different subtypes, and this is going to be a lot more aggressive than the Hodgkin's lymphoma. It's going to be more common in older adults, and it can happen in any lymph tissue, not just the cervical nodes. And it has a spread pattern that is a lot more unpredictable, and it's usually diagnosed later when it's harder to treat. And we're also going to have similar treatments here like chemotherapy. We might use monoclonal antibodies, or we may have stem cell transplant similar to leukemia for some aggressive types. And of course, I want you to remember to monitor neutropenic precautions, both for leukemia and for lymphoma patients, and to watch for tumor lysis syndrome after chemotherapy. Let's talk about some of the risk factors here. Now, environmental toxins, as well as prior cancer treatments, can damage the DNA, and they can raise leukemia and lymphoma risks. So, different toxins in our environment can definitely raise the risks for people to develop these cancers. Of course, also the Epstein-Barr virus has been associated with Hodgkin lymphoma. Now, Down syndrome, surprisingly, actually increases the risk of the ALL type of leukemia because of chromosomal vulnerability. So children who have Down syndrome may be at a higher risk to that type of leukemia. And then if we have clients with immune dysfunction, such as from HIV, or if they are having immunosuppressive therapy for any reason, like for an autoimmune condition, that can also increase their susceptibility to lymphomas as well as to aggressive leukemias. So we have different kinds of triggers here. We have toxins, we have genetic triggers, we have immunosuppression, and we have viral triggers as well. So lots of different risk factors. And then leukemia, the symptoms are going to stem from the bone marrow failing. So you're going to see, like I mentioned earlier, you're going to see anemia, you're going to see neutropenia, and you're going to see thrombocytopenia. These are going to be hallmark signs of leukemia, whereas lymphoma is usually going to present with painless lymphadenopathy, especially in the neck, armpits, or groin. So usually if there's like swollen lymph nodes in the neck area, in the armpits, or in the groin area, that could be an early sign of lymphoma, and it's going to be a painless swelling. And then, of course, there will be other symptoms like night sweats, fever, and weight loss. These are going to be red flags. They're going to be later symptoms that the lymphoma is actually becoming systemic. There is a worse prognosis. It is spreading, and the involvement is a lot larger at that point. Now for diagnosis here, like I said earlier, we kind of jumped into it a little bit, but let's dive in a little deeper now. A CBC and a biopsy are going to be the cornerstones of diagnosis here. And then a flow cytometry is going to help to identify specific cell surface markers that are going to tell us what kind of leukemia we're dealing with. So CBC and biopsy for leukemia. And we're going to have chemotherapy as a first line treatment, and for more aggressive regimens too for acute forms of leukemia. We're also going to have targeted therapies for leukemia type CML, especially. We're going to have targeted therapies that are going to block abnormal proteins like certain medications like Gleevec. And then stem cell transplant is also an option. It is considered for high risk and relapsed patients. These are going to be some treatments that are going to be synonymous for both conditions. And then, of course, we're going to watch for tumor lysis syndrome. This may be something that may appear on the NCLEX. Tumor lysis syndrome is going to be a metabolic emergency. It is caused by rapid cell death, and it's highly testable on the NCLEX. So some of the symptoms are going to be hyperkalemia. So we're going to have high potassium. We're going to have high uric acid. We're going to have high phosphate and low calcium. So hypocalcemia, hyperphosphatemia, and hyperkalemia, and then high uric acid as well. So we're going to monitor for this in patients that had chemotherapy. So if you get a question about a patient who had lymphoma, they recently had chemotherapy and now their potassium is high, they're having hyperphosphatemia and they're having hypocalcemia in their labs after you reviewed them, what are you suspecting? And that's going to be tumor lysis syndrome. Again, it means cells are dying rapidly. So it's something that we need to detect very early. Now let's talk about some questions here, like what type of leukemia is most common in children? And that's going to be the acute lymphocytic leukemia. What lab finding is expected in leukemia? That's going to be decreased red blood cells and platelets and abnormal white blood cells. Now, what cells found in Hodgkin lymphoma? This is going to be the Reed-Sternberg cell, like we talked about. It's a pretty distinctive name, so you'll likely be able to remember that. And then what's the priority nursing action for a neutropenic leukemia client? And of course, we were going to want to implement neutropenic precautions really all across the board for both of these, but especially for a client that is already in neutropenic state, which is going to be really, really frequent and effective hand hygiene, no fresh flowers, no raw foods, masking, and of course, screening their visitors to make sure they haven't been around anyone who's sick or that they haven't been sick recently. And then what is a dangerous complication after starting chemotherapy? And that is going to be the tumor lysis syndrome. Let me check back in on you guys here, see if you have any questions. I got that question in my NCLEX, Hodgkin's disease. Yeah, it's actually a common topic on the NCLEX. So I'm glad that you guys are here listening.
Maria,
Do you guys have any questions before we jump into our NCLEX style questions?
so did you just say that CML is most common in adults?
I'm sorry, say that again?
Did you just say CML is most common in adults?
Yes, let me go back to that slide for you here. Let's go back to our risk factors. Or actually, sorry, that was in this one. So yeah, so CML is most common in adults. CLL is also most common in adults, older adults specifically. And then ALL is going to be the kind that's most common in children. So, and then I have something here for you. CLL and AML, older adults, and then ALL in children. So that's kind of like that little hint when you get a case study that's telling you their age. Those are going to be the types that are most common.
Okay, thanks.
You're welcome. Do we have any other questions? All right. If you guys have any questions and you're too shy to say them out loud, just drop them in the chat and I will go over them for you. Come again with tumor lysis syndrome. You guys want me to dive a little bit into tumor lysis syndrome? I would be happy to do that. So tumor lysis syndrome, like I said before, it is a complication of chemotherapy. It is going to be life-threatening. It's going to happen pretty fast. And it actually means that the cancer cells are going to break down very, very fast after the chemotherapy. And what that's going to do is it's going to release the contents of the cancer cells into the bloodstream. And that is going to lead to electrolyte imbalances. You are going to have, like I said, high uric acid, high potassium, and high phosphate levels. And then you're going to have low calcium levels. And it is going to be most common with the two cancers that we just talked about, the lymphomas and the leukemias, but it can also happen with other cancers. So some of the symptoms that you might see in your patients is nausea and vomiting, right? Because we're having electrolyte imbalances, we are going to have nausea and vomiting, diarrhea. Because of the low calcium, they may have muscle cramps, weakness, as well as neurological changes. And of course, because of the high potassium the high potassium and the high phosphate is going to be really, really taxing on the kidneys, right? So that could cause acute kidney injury. So you may see some kidney related symptoms. And then of course, because again, we are still messing with potassium and calcium, and the heart is a muscle, you might see some cardiac sensitivities as well. You may see some cardiac arrhythmias, some changing rhythms, and then you may see seizures and even death. So very, very scary complication here of chemotherapy, the tumor lysis syndrome. I hope that answers your question. Are you saying that for tumor lysis syndrome we'll have most electrolytes high except for calcium? And that is correct.
So in that, sodium is not affected? The sodium levels are not elevated?
So I know that, where sodium goes, water flows, right? So of course we're going to have hyperkalemia is going to be the biggest thing here. I don't know if it really affects sodium as much. I don't think sodium is going to have a major kind of function in this tumor lysis syndrome. So I don't really think there's going to be it's not going to be like a key finding that you're going to see where the sodium is like too high or too low. It is primarily going to be just the phosphate and the potassium as well as the calcium. Those are the little combining electrolytes there where you're really going to see the key findings of the tumor lysis syndrome. Guys are asking excellent questions. Any more I can answer for you?
Is superior vena cava syndrome is also a complication of this lymphoma.
Of which one?
Superior vena cava syndrome.
And you said it's a complication of which one?
Lymphoma. Is that a complication? I'm asking. I'm not sure.
Oh, okay. Superior vena cava syndrome. And I thought you were talking about the tumor lysis syndrome. So let me see. I'm trying to see if I can pull up an image for you guys here so you can see. I'm trying to pull up an image so you guys can see the superior vena cava syndrome here. Actually, the type of lymphoma that is most associated with that would be Hodgkin's lymphoma. And you know, because we have the swelling of the lymph nodes in this area, because those lymph nodes can grow really large in all the different areas of the body, including in the chest, they can cause that constriction and that blockage. And I'm trying to look for a good image here for you guys so you can see that, but I'm not really finding one. But you're absolutely right. It is associated with lymphoma, and specifically the Hodgkin's lymphoma more than any of the other ones. But it can cause a blockage, and because of the obstruction, unfortunately, there's no good images here for me to show you guys, sadly. But yeah, it can cause an obstruction. The lymph nodes in the chest as well as the neck can swell up, and then they can kind of cause an obstruction of the superior vena cava, and that can lead to the superior vena cava syndrome, and it can of course block perfusion to the body, to the brain, to the heart. It can cause shortness of breath. It can cause chest pain. So that is a complication that you guys should be aware of in the clinical setting. I haven't seen this complication so much show up on the NCLEX, but it's definitely something that is really good for you to be alert of. The way that you would manage this complication, of course, you need to first figure out the underlying cause. If you already know that your patient has lymphoma, then you would know likely that's the most likely cause of them having that superior vena cava syndrome. But if they're just coming in to the emergency room, if you're in a case study, right, they're just coming in, they're having superior vena cava syndrome, and you're trying to figure out what the root cause is. Then of course you need to figure out what that is, and if it is lymphoma. If it is lymphoma, then the treatment is going to, of course, include the treatments for lymphoma, which would be like chemotherapy, radiation therapy. They may even need to do like a stent to relieve the obstruction. But yeah, that was an excellent question. I love that. Thank you so much for bringing that up. Let me see what else you guys said here. Yes, so superior vena cava syndrome is another complication of lymphoma. I see someone saying when calcium is low. Yes, calcium is going to be low with this: high potassium, high phosphate, low calcium, high uric acid. And then what is the difference between Hodgkin and non-Hodgkin? Let's go ahead and go back to that so we can talk about it. So the Hodgkin lymphoma, like I said, is we're going to have those Reed-Sternberg cells with them. And it's going to be, non-Hodgkin is going to be one that has a lot more subtypes. It's going to be a lot more common. Let me go ahead and tell you a little bit more here. Let's jump into the risk factors so you guys can see too.
Can you repeat what you said, Maria?
Yeah, absolutely. So we had a question in the chat about the difference between Hodgkin and non-Hodgkin lymphoma. So the Hodgkin lymphoma is going to be marked by those Reed-Sternberg cells. That's something that you might see mentioned on the NCLEX, whereas the non-Hodgkin lymphoma is going to be a lot more common than the Hodgkin lymphoma, and it's going to be you're going to be found it in a lot more people, and you're going to find it with a lot more different subtypes. So there's going to be a lot more different subtypes of the non-Hodgkin lymphoma.
I have a question.
Yeah.
This hallmark sign for Hodgkin lymphoma, is there any other way it can be addressed in events we didn't see Reed-Sternberg cell? Is there any other way it can be interpreted and you still know that it's this same hallmark sign that you're talking about?
So the hallmark signs of Hodgkin lymphoma, they're usually going to be, they're going to do a biopsy to find those abnormal B cells, which are the Reed-Sternberg cells.
Okay.
Yeah, they're going to do a biopsy, and then this is going to be a lot more common in young adults and teens. So this is going to, whereas non-Hodgkin lymphoma is going to be more common in older populations. And then another big difference here is going to be that the Hodgkin lymphoma is going to start in the cervical lymph nodes, and it's going to be very predictable in the way that it spreads from lymph node to lymph node. And typically, typically the Hodgkin's lymphoma is going to have a really good prognosis. So people are a lot more likely to recover from it with treatment. Whereas the non-Hodgkin lymphoma is going to spread in a way that's a lot more aggressive. It's going to be a lot more unpredictable in the way that it spreads. And it's also going to be, like I said, common in older adults. And it's going to rise in any lymph tissue, not just cervical lymph tissue. Both of them are most likely going to be diagnosed with biopsies, and both of them are going to be treated with chemotherapy, with different types of chemotherapy, but they're both going to be treated with chemotherapy. And then in non-Hodgkin's lymphoma, they may also include monoclonal antibodies, as well as stem cell transplants. Does that answer your question? So if you see on the NCLEX the Reed-Sternberg cells, you're always going to think Hodgkin. And then if you don't see the Reed-Sternberg cells, then you're going to think non-Hodgkin lymphoma. And if you see non-Hodgkin without the Reed-Sternberg cells, you know that this type of lymphoma is not going to be predictable. It's going to be a lot more aggressive. There's going to be more different subtypes of it, and it's going to be a lot more varied than the Hodgkin lymphoma. And it's going to have a less good prognosis, whereas Hodgkin lymphoma with treatment is going to have a better prognosis. It's going to be less aggressive, and it's going to be a lot more predictable. I hope that answers it for you guys. Let me know if not. I can go deeper into it. Yeah, absolutely. You're very welcome. Yeah, and then of course, we're always going to be looking at our labs, right? Labs are always going to be a key indicator of all of these conditions. So if you guys are ready, I'd like to jump into our questions so we can apply some of our knowledge that we reviewed today. And I'm going to go ahead and read the first question for you. And I'd love for someone to unmute and tell me what they think the answer is. So a nurse is caring for a client diagnosed with pernicious anemia. Which of the following findings would the nurse expect to assess in this client? So this question is asking us about pernicious anemia. And it's letting us know that this person, we're looking for a finding that's expected with this condition, right? So is it going to be yellowish skin tone, glossitis, decreased white blood cell count, or elevated hemoglobin level?
Glossitis.
Yep, you're right. I love it. Let me see what you guys are saying in the chat. Do you agree? Yep. Glossitis, that is going to be an expected finding here. Why is that, right? So when we have a lack of vitamin B12, which is what's happening with pernicious anemia, we talked a lot about this one. This does make the tongue look red, sore, and beefy, and swollen and smooth. That's just something that happens in the body when there is a lack of B12. Now, for option 1, yellowish skin tone, we can have jaundice and hemolytic anemia. It's not really a sign of pernicious anemia. With pernicious anemia, we're actually going to have more paleness rather than jaundice. Now, decreased white blood cell count is called leukopenia, and this isn't necessarily a characteristic of pernicious anemia because this type of anemia is actually going to affect the red blood cells, and it is not associated with a decreased white blood cell count. It's more associated with large immature red blood cells, right? And then an elevated hemoglobin level is wrong because we would actually expect to see a low hemoglobin level because it's a type of anemia, right? An elevated hemoglobin level would indicate a different condition. So who would like to read number 2 for me?
A nurse is caring for a client with sickle cell disease who is experiencing a pain crisis. What is the priority intervention? Administer oxygen therapy to increase oxygen levels, administer prescribed pain medication to relieve discomfort, encourage the client to drink plenty of fluids, initiate blood transfusion therapy as ordered. And my answer would be number 2.
2.
I
Number
love
2.
it. You're
Number 2.
absolutely right. Yeah, and we talked about this in a lot of our slides when we were talking about our sickle cell crisis, right? And the reason why is because pain is going to be the biggest and most severe symptom of a sickle cell crisis. We really need to go ahead and kind of relieve that discomfort in those patients. Pain is going to be really high. It's going to be really severe. It's always going to be the priority. We're going to treat pain first, and then we're going to go ahead and handle everything else after. And the reason why is because you guys remember the triggers of sickle cell, right? One of them is stress, right? And when you're in pain and you're stressed, everything is going to be going off in your body. Like, especially with severe pain, your body is going to be in so much stress. It's just going to be releasing a lot of different like cytokines and inflammation and all over widespread. So if we lower that pain, we calm that person down, that's going to help a lot to manage the crisis that's going on. So and it's also going to prevent more complications from happening. So that's going to be the number one intervention. Option 1 here was to administer oxygen. The reason why we didn't choose that one is because that one is going to be secondary to managing the pain in sickle cell crisis, unless of course that person is hypoxic and they are showing signs of respiratory distress. Then we would manage their oxygenation first, but otherwise standard priority is always going to be to manage the pain with sickle cell. Encouraging the client to drink plenty of fluids. We love hydration. That's going to be part of our prevention education, and it's going to be part of like the prevention process, right? It's going to reduce the risk of the sickle cell crisis, but in the immediate crisis, we are going to manage the pain. And then initiating blood transfusion therapy may be a part of the treatment, but it's not going to be the first priority unless, of course, it's specified, and we already know that that's the doctor's orders. Anyone want to read number 3?
Nurse is assessing a client diagnosed with iron deficiency anemia. Which of the following is a common clinical manifestation of iron deficiency anemia? Cyanosis of the lips and extremities, pale dry skin and brittle nails, severe headache and blurred vision, warm flesh skin with elevated temperature.
I would say 2.
Yep, you're right. It is 2. Let's see what you guys are saying in the chat. Do you think it's 2? And also, if you ever feel like you think it's a different answer, feel free to discuss with me why you think it is. So you guys are absolutely right. It is option 2 here. Let me go ahead and show you the rationales. So we know that, let's go into it kind of in order, right? Cyanosis of the lips and extremities. Again, this is going to be a sign of hypoxia. This is going to be a lot more common in different conditions, not necessarily in iron deficiency anemia. Even if there is a lower capacity for carrying oxygen to the tissues, it's not really going to be a symptom here. It's actually going to be pale, dry skin and brittle nails. Those are the hallmark signs. And the reason why is because we have reduced levels of hemoglobin. These do affect your skin. They do affect your nail health because, again, these are like far, far extremities where the body has to carry oxygen to, right? So it's definitely going to be the first one that's kind of affected. And then, of course, we have pale skin. Again, because, you know, this is just one of the symptoms. We have less oxygen delivery to the farthest areas of the body. So that's just going to be a resulting symptom of it. Now with number 3 here, we have severe headache and blurred vision. Not really a characteristic. This is going to be more characteristic of a hypertensive crisis. But with iron deficiency anemia, we're going to have a lot more fatigue, and we might have dizziness too. And then warm flushed skin with elevated temperature. This is going to be more likely to be seen if you're having a fever, some kind of an immune reaction to something, or an inflammatory condition, but not really iron deficiency anemia. Does anyone want to read number 4? And I can jump in and read it here for you guys. So a nurse is assessing the risk factors for DIC in a client. Which of the following are risk factors for DIC? Select all that apply. So we have severe trauma or burns, infection, particularly sepsis, chronic kidney disease, complications of pregnancy such as preeclampsia, or myocardial infarction. Now we know that DIC is a secondary condition that comes after something that triggered the body into that severe state of stress, right? So what do you guys think is going to be the conditions that trigger DIC here?
For sure, 1 and 2.
1 and
1 and 2.
I know 1.
1 and
I
4.
know 2.
Number
Yeah.
4.
4, maybe.
I don't.
1 and 4.
It's 1, 2, 4.
It's 1, 2.
1, 2, 4. Yeah.
I love that you guys are absolutely on the right track here. You're giving me the right answers. It is 1, 2, and 4. Let's go ahead and take a look at our rationales here. So we know severe trauma and burns, right? We talked about that. If we have trauma that can lead to major injury and lead to a systemic inflammatory response, this can be a risk for DIC. If we have infection, particularly sepsis, can also be something that can cause the whole body to just go into a really, really inflammatory storm. And then complications of pregnancy like preeclampsia, which can cause placental abruption, right? So we know that those are definitely risk factors. You guys were absolutely right. Now, chronic kidney disease, not necessarily a risk factor. And myocardial infarction, also not necessarily a risk factor, although they may have some overlapping symptoms here and there, but not really what we're looking for when it comes to DIC. And then question 5, if anyone wants to read it. If not, I can jump in.
A nurse is providing discharge education to a client newly diagnosed with hemophilia A. Which statement by the client indicates a correct understanding of the teaching? I can take ibuprofen when I have joint pain. I should wear a medical alert bracelet all the time. I needed to receive weekly vaccination to prevent bleeding. I will increase my intake of green leafy vegetables to help clotting. So
I think it's
I would
number
say
2.
2.
Number
2.
2.
Yeah.
Look at you guys. Absolutely. You are correct. It would be number 2. You're absolutely right. You know, we have some medical contradictions in the answer options there, right? Like number 1, I can take ibuprofen. Definitely not recommended. We talk about NSAIDs like aspirin and ibuprofen being contraindicated in hemophilia. So definitely no, that was a distractor answer. Option 3 was receiving weekly vaccinations. We don't currently have any vaccinations that can prevent bleeding, right? Vaccinations are going to treat are going to be able to prevent certain diseases, but not necessarily that. We're actually going to need the replacement of clotting factors, not vaccinations. And then green leafy vegetables. Yeah, this could be a long-term dietary management, right? It definitely can help, but it's not going to be the best intervention in this list. The best intervention would actually be to wear medical alert bracelet. And why is that? And that's going to be because if there is some kind of a traumatic event where they have, a laceration or, some kind of let's say an accident or something, emergency responders need to be aware that this patient has hemophilia so that they don't do anything that could make the situation worse. So that's definitely going to be the best safety intervention there. Question 6 here. Who wants to read this one?
A nurse is planning care for a client diagnosed with hemophilia. Which of the following interventions are appropriate? Select all data blood. Administer prescribed factors. 8. Replacement therapy. Avoid intramuscular injections whenever possible. Encourage high contact sports to improve mobility. Apply ice to joints at the first sign of pain or swelling. Use aspirin for pain relief as needed.
I would say
The
1 and
actions.
4.
1
1
and
and
2.
4.
1,
And
2,
4.
4.
1
4.
2
1 to 4.
4.
No
1 to 4.
intramuscular injection.
Oh, yeah.
1
1
to
to
4.
4.
1 to 4.
1 to 4.
I
Avoid
love it.
intramuscular injection.
Yeah, you guys are on it. I
Yeah,
love
avoid,
that.
yeah.
Yep, exactly. Yeah, you're absolutely right. We
What is
know.
the answer?
Say that again.
What is the answers?
Yeah, so these,
1,
no, you
2,
guys
4.
are absolutely correct.
1 to
1, 2,
4.
and 4. Yeah, you guys are on it. I love
Oh,
that. So when you replace the factor 8, again, we talked about replacing what's missing, right? This is actually going to be the most important treatment here to prevent the bleeding. So we are going to go ahead and replace those factors that are missing. We are going to avoid intramuscular injections, right? Because these can cause hematomas, and then we can have occult bleeding in there, right? And then ice to joints. Again, we can have occult bleeding in the joints. That's why we get the swelling, the hematomas, the pain. So we remember our rice mnemonic. So we're definitely going to apply ice because it is going to reduce inflammation and bleeding. Again, encourage high contact sports. Definitely a contradiction here. We don't want these patients to be in high contact sports because that can really significantly increase the risk of trauma and bleeding. And then we also know that aspirin, again, is going to be contraindicated in this condition. So acetaminophen or paracetamol would be the best option for these clients.
Because there's no clotting factor.
Yeah, exactly. So why are we going to give them aspirin? Yeah, you guys are so right. I love that. All right. If anyone wants to read number 7 here.
a nurse is assessing a client with a suspected acute myeloid leukemia. Which of the following clinical features should the nurse expect? Select all that apply. Petechi and eschimosis, elevated lymphocyte counts, gingival hypertrophy, hypercalcemia, increased production of mature neutrophils.
Petechia
I
or
would say
leukemia.
petechia,
Increased.
elevated
3.
lymphocyte count, gingival hypertrophy,
Making 1 and 5.
1 and 3.
1 and 3.
It is 1 and 3.
Yeah,
You
1 and
are
3.
correct. I love it. You guys are so on this. Okay,
When
so
it
number
comes to
1.
the test, you're going to be nervous.
No, that's okay. It's okay to be nervous. That doesn't mean you're not going to get it right. You're just going to take a deep breath and then you're going to get the right answer.
I always screw up with the test.
Yeah.
Yeah,
But you
because
won't.
it's not really a test right now, so it's so easy and more
Yeah, you are
relaxing.
relaxed.
But when you get to the test, that's where the problem comes in. The anxiety just like, kill me now.
Yeah.
You just got to remember when you're in the test, you're going to take a deep breath between questions. You're going to break down the question. You're going to eliminate those answers that look incorrect. And then you're going to be left with 2 like really good options. And you're going to remember like one specific thing. And you're going to be like, aha, it's this one. So you'll know, you'll definitely know, especially because you're here and you're dedicating the time to practice. So that's the most important thing. But
I have a question though. Like when you're taking like a test, right? And say for instance it's a multiple choice, like a SATA question, right? And it might have maybe like 4 different answers there, but you only remember one that you're sure of. Should you just take that one and go with it?
I always say that with test taking, like go with your first instinct. Like usually the first one you move towards is the one that's right. Of course, there's variations to that, you know, but they always say go with your gut. Like the first one that you think about is usually the right one. But if that's the only one that you remember specifically associated with that, then I would definitely go with that. Like if you're looking at the other answer options and it's just not bringing back anything to mind, like you're just like, I really cannot remember if any of this has to do with the question, definitely go with the one you know. I would definitely do that because that's going to give you
better to get one than a zero, right?
yeah, exactly. It's going to give you a much higher chance of getting that one correct. But always think about keywords in the question because sometimes that's going to be all it is. It's going to be that one keyword in the question and that one keyword in the answer. And another thing, never choose a partially correct answer. You always want your answer choice to be like entirely correct. Yeah. So definitely. And these are all great questions. If we had had more time today, I would have gone over our test taking strategies, but we had a big topic.
Can I see the question again?
Yeah, absolutely.
Go back. Yeah.
So let's break down this question. So we have the nurse assessing client. The client, we don't know if they have it. They're suspected to have acute myeloid leukemia, and we're looking for some clinical features that are expected with acute myeloid leukemia, right? So we have petechiae and ecchymosis and gingival hypertrophy. And so what that means is petechiae and ecchymosis are going to be like bruising and purple spotting of the skin. And this is going to be happening because of thrombocytopenia, because of the bone marrow suppression. So this is going to be a hallmark finding of this type of leukemia. And then gingival hypertrophy, which is like swelling of the gums, that's going to be observed in this condition because it's a result of the infiltration of the gum tissue. So there's going to be a lot of inflammation in there. The gum tissue is going to be swollen. And kind of like bigger than normal. The reason why we didn't choose elevated lymphocyte count is actually because this is more characteristic of lymphoid leukemia. And we were talking about acute myeloid leukemia here. So the acute lymphoblastic leukemia, which is ALL, is an example of that. And that involves immature myeloid cells. So hypercalcemia is not going to be a typical feature of AML. It's actually going to be more commonly seen in the multiple myeloma or in advanced cancers with metastasis to the bones, right? So if we're having metastasis to the bones, we're going to see the breakdown of calcium that's going to go into the blood, and then we're going to see that elevated calcium in the blood. And then the increased production of mature neutrophils, also not expected in AML. In this one, it's going to be, we're going to have a functional neutropenia, even though there's a white blood cell count. But it's going to have a proliferation of immature myeloid precursor blasts in this one. So again, there's like a lot of really like specific things about these, but I don't want you to get too like tied up in those genetic and pathophysiological aspects of it, more so in what the hallmark signs of each one is. Go ahead and do question 8 here. I'll go ahead and read it to you guys. It says, a nurse is caring for a client with suspected neutropenic sepsis. Which of the following is the priority nursing intervention? We have initiate broad spectrum intravenous antibiotics. We have administer antipyretics for fever, obtain a complete blood count with differential, or place the client in protective isolation. So we're suspecting neutropenic sepsis. What do you guys think is going to be the very first thing we need to do for them?
Number 4.
Number 4.
I like your thinking, but there's one more thing
I
that you
go
should
with
do first.
one.
Number 1.
One.
Yeah. Yep. Absolutely. Number 1, we're going to initiate broad spectrum antibiotics. And again, we don't like to do broad spectrum unless we have to. We like to get our blood cultures first, right? So we could see what we're dealing with if we have time. Now, if this person is a neutropenic sepsis, things could go bad very, very quickly. So that's why we need to go ahead and initiate those broad spectrum antibiotics. And then after we can get a blood culture, let that run, and then figure out what other more specific antibiotic therapy we need to do after that. But we need to at least initiate that broad spectrum antibiotic therapy so that it starts doing something in the time being, so we can slow down that process and, you know, not let our patient die. Of course, antipyretics are going to be helpful for fever, but that's going to be more of like a management, not so like targeting the root cause of the problem.
So for number 4, is it because the person is not really contagious? Why that would be the first?
So the reason why we didn't do number 4 is because number 4 is what we're going to do in order to prevent them from getting that infection in the first place, right? We're not really, so what the question is really asking us here is, what is our priority nursing intervention? Like, what that means is, what do we need to do to stop this client from dying, like right now, this very second, right? The first thing we need to do, the most important, most effective intervention we need to do to stop them from dying. If we put them in protective isolation, that's more of a management to prevent them from catching anything else. I mean, they could definitely, if they're already in neutropenic sepsis, they could catch a secondary infection and make the situation much worse. But that's going to be something that we're going to do secondary to initiating antibiotic therapy, because antibiotic therapy as fast as possible is what's going to stop that bacteria from growing and from, causing widespread sepsis and killing the patient. So
I asked because, someone says 4, so that's why I asked.
yeah, and that was a great question, because usually in neutropenia, that's what we need to do, is we need to put them in isolation from other people to protect them from catching any infections, because their immune system is in a very compromised state already. But in this case, antibiotics would come first, and then we would also put them in an area where they're, protected from getting another secondary infection. But again, antibiotics are going to be the first most effective intervention.
Professor, I have a question about the antibiotics administrations. I remember in nursing school, my last professor for medicine said that we had a time frame to get the cultures before we suspend treatment, because it has to be justified by something.
Yeah, you're absolutely right. And in a lot of conditions where we can wait for the culture, we would only be getting the culture first, right? We'd be getting the culture, and then we would be administering only the antibiotics that are specific to the pathogen that we're fighting. But in this situation, because this person's body is in neutropenic state, they already can't fight the infection, and they're already becoming septic from the infection, which means the infection has already spread and it has already caused multi-organ failure in the body. So at this point, they are one step away from death, which means starting broad spectrum antibiotics while we gather the blood cultures to figure out what specific antibiotic we need is kind of going to give them a temporary slowing of the progression of the sepsis. Does that make sense?
Yeah, but he said there was a time frame, like I don't know if it was 72 hours to get the culture, to get the
Yeah.
results to justify the treatment.
Yeah, I guess that depends on the facility that you work at too. So like different
Mm-hmm.
facilities are going to have different regulations, and they're going to have different standards for the time that you have in order to like gather the culture and administer the antibiotic, or like you said, to justify what antibiotics you're giving. So that's really going to vary per facility protocol.
But
Okay.
in this question, it actually tells you already that the person has a neutropenic sepsis. So that way you can treat it and then go on to the culture, because it already tells you what the person has.
Yes, exactly. So yeah, absolutely. So in this case, we already know they have neutropenia. We already know they're having sepsis, which means the infection has already progressed so heavily all over the body that it's causing multi-organ failure. And that means we need to like immediately start some broad spectrum antibiotics, because we need to stop that progression right away, so that they don't go into shock and then die. Yeah, I
And
hope that.
I think that is the more reason why it is important to isolate them before commencing the treatment. In that we know that this person is immunocompromised.
Yeah.
So mixing that patient, adding him or her up with the others, you never know the kind of infection that person has. So
Yeah.
this school of thought will also tell you that yes, isolation is management, but then it is very important just because even if we are doing the nursing, rendering the nursing services, we are to gather all the, what do you call it, the nursing procedures at a goal. We shouldn't be
treatment.
let visitors come in, people who are coughing and all sorts of things. So it is very, very important to me that patient should be isolated before commencement of the treatments. That is me.
Yeah, no, that makes
Yeah,
sense.
me
And
too.
if, let's say the question was asking, your patient has suspected neutropenia, not suspected neutropenic sepsis. Your patient has suspected neutropenia. What is your priority nursing intervention? Now that would change the scenario completely, because we would not be administering antibiotics. Our primary priority nursing intervention for a neutropenic patient would be to put them in protective isolation. So you're right. Before they develop sepsis, that would be the preventive measure, right? It's going to be the most important preventative measure for us to prevent them from developing an infection that could turn into sepsis. So you're absolutely right. As a nurse in a crowded facility with lots of different people with lots of different conditions and infectious diseases, we want our neutropenic clients to have strict isolation and to have strict protective measures so that this doesn't happen to them. So you're absolutely right about that. That is a very, very important intervention.
If, for example, they say that it was a suspected tuberculosis, what will be the priority? It's going to be antibiotic or put them in
isolation.
Isolation.
That's a flip for that one right there.
Yeah.
Well, if your patient had suspected tuberculosis, the first thing we'd probably do is put them in isolation, but that would be more so to protect the other patients and ourselves. If we're talking about an intervention to treat our patient with tuberculosis, that would be different, right? But the isolation would more so in that case be to prevent the rest of the unit from contracting tuberculosis.
Yeah, because it's airborne. Right.
Yeah, absolutely.
So that's a difference there with the suspected sepsis and the tuberculosis. That's a big difference there.
Yeah. Thank you guys. Those were really excellent questions. I appreciate that. Let me see here. What else? Let's look into our next question. So I'm going to read number 9 to you guys. A nurse is reviewing client charts to identify those at risk for oncologic emergencies. Which of the following conditions is classified as an oncologic emergency? And look at that. We have the option that we talked about earlier because one of our students brought it up, and I love that. We have superior vena cava syndrome. We have iron deficiency anemia, deep vein thrombosis, and hyperlipidemia. What do you guys think it is?
Number
one, superior vena cava.
I love that. And I love that you guys asked about that earlier. And that's why it's so important for you to ask questions. And I appreciate you guys participating. Again, superior vena cava syndrome, we have the lymphoma swelling up the lymph nodes in the chest, compromising the airway, and really blocking and occluding blood flow from the heart or to the heart. So it's really important for us to be able to assess for that. And our incorrect answers here, we have iron deficiency anemia. Again, this is important to manage, but it's not a life-threatening event. We're talking about oncologic emergencies, right? Deep vein thrombosis, again, serious. This is more of a thrombotic emergency than an oncologic emergency. And then hyperlipidemia, we have, not necessarily an oncologic complication. This is more of like a lipid metabolism thing, right? This just means we have high cholesterol, basically. And then we have question 10. Who wants to read this one?
A nurse is planning care for a client diagnosed with lymphoma. Which of the following interventions are appropriate for this client? Select all that apply. Yes, one is there.
Encourage hyperpix now. Educate the client on needs for regular cancer screening. They already have cancer, so they don't have to be screening.
4 is there.
1, 3, and 4.
Yeah,
1, 4, 3.
Yep. So we're planning care for a client. They're diagnosed with lymphoma, and we're looking for interventions that are appropriate. You guys are right, 1, 3, and 4.
Yeah.
We need to monitor for signs of infections because if they are neutropenic and they're receiving chemotherapy, they're always at risk of infection. We also need to educate them on screenings that are regular so that we can monitor for follow-up and secondary cancers. And then, of course, we need to provide support and resources because a cancer diagnosis can be extremely scary. The patient can become extremely depressed. It can
Stage
be
and grade.
cope. Yeah, so that's definitely going to be a really, really important and really like underspoken about, right? Is the psychosocial support. Now, high impact exercises are not going to be recommended for these patients because they're a lot more strenuous. Low impact activities are going to be like yoga, like Pilates, like gentle resistance training. These are going to be a lot more appropriate to these cancers. And then we also don't want to restrict fluid intake unless there's a reason to restrict fluid intake, like with heart failure. We want these patients to actually be adequately hydrated. We want to protect their kidneys. So we definitely don't want to restrict fluid intake. It really doesn't have anything to do with lymph node swelling. This might be kind of an interconnection with like when you have fluid retention. Definitely not the same thing as lymph node swelling here.
What about pool exercise?
Yeah, pool exercises are excellent. These are great low impact exercises. They're actually really safe on the joints and on the body generally. So these are going to be another really great option for these patients. Thank you for mentioning that. So I'm going to give you a small little review here of everything that we talked about. We started out with anemias, understanding the differences between iron deficiency, pernicious, and sickle cell anemia. And we talked about MCV levels with microcytic and macrocytic anemias. We talked about causes and symptoms like fatigue, pallor, tachycardia. And then we moved into bleeding disorders like hemophilia and disseminated intravascular coagulation. We know that these are high priority conditions on the NCLEX because of the risk of hemorrhaging, shock, and organ failure because of hypoperfusion. And then we also talked about leukemias and lymphomas, which was a more complicated topic. So now you know how to classify them, spot critical symptoms like having lymphadenopathy, fever, and also anticipating some complications like tumor lysis syndrome or even neutropenic infections that can lead to sepsis. So I just want you to remember on the NCLEX to remember your interpreting your lab values, like your CBCs, your coagulation panels, and then remembering biopsies as a part of the diagnostic process. And then, of course, prioritizing interventions for bleeding, infection, and anemia, and using your critical thinking to respond to signs of the body decompensating. But I also want to thank you guys for your engagement today, for your energy, for all your excellent and amazing questions. If there's anything that you want to, review again before the test, I would highly recommend that you rewatch the webinar or that you download the slides and look at them. I actually uploaded the updated slides here into the chat box, but I'm going to upload it one more time before I leave because I know my last slides that I was showing you guys was missing the slide about the management of the anemias. So I am re-uploading it here for you guys. And I don't know what happened. I'm having like a tech issue that my video is just not working right now. That's why the meeting kind of like I disappeared and came back earlier, but for some reason it's not working. But I hope that you guys got all the explanations that you needed. So the way that you can rewatch the webinar is you go into your Naxlex, and on the left taskbar, you're going to see an area called previous webinars. And in the previous webinars, you're going to find all the different webinars that we've already had with the PowerPoint slides attached to them. So you guys can go ahead and click on that, and you'll be able to see all of our webinars that have already happened, and you can download the slides alongside with them. So, and then I just, oh, go ahead.
For the lab values, do we get those lab values on the NCLEX?
Yes. So the next gen NCLEX will actually give you the lab values. You won't need to remember those on your own, but I still recommend that you be familiar with them and that you remember those lab values so that it can make it easier for you to answer the questions like right off the bat. But you do get a long time to take the test too. So you should be okay if you forget a couple lab values here and there. But yeah, that's the cool thing about the next gen is that it does give you the lab values. So I love that.
Please, did you say we can download the slides or the audio?
Yeah, so if you go into the previous webinars section of the NXLEX website, you will see the previous webinars, and you can actually rewatch the webinar and you can re-download the slides. And I actually just provided the current slides for this webinar. I just uploaded them to the chat. So you can go ahead and click on it and download it directly from here.
You can download the slides, but you cannot download the audio.
Yeah, not the audio, unfortunately, but you can rewatch the presentation if you'd like. And I just sent a screenshot into the chat that shows you where to find the previous webinars.
Thank you.
You are so very welcome, you guys. We ran a lot over the time today. I do apologize for that, but we had a big topic. So, and thank you for hanging with me through these random little tech issues that happen here and there. But you guys have been so wonderful, and you guys did so great with your critical thinking. I know that you're prepared.
Thank you so much, Maria.
Good night.
Thank you. I hope you guys have a great night wherever you are.
Good night.
Have a
Thank you,
good night.
Maria.
Thank you
Thank
so
you.
much, you guys.
Thank you so much, Maria. It was a great session.
Oh, I'm
Thank
so
you
glad
so
to hear
much.
that.
Yeah.
I'm really glad. Thank you. All right, you guys. So I do see a question here. When are you guys going to have a webinar with me next? So I do webinars. My next one is going to be 4/29. So in 4 days, we have a maternal newborn health webinar on care of the newborn. And then on the 1st of May, I'm doing one on oncology and palliative care. So we're going to carry on a little bit from the top.
I need that newborn one.
Yes,
I really
for
don't like peds. I don't like peds.
Yeah, peds and maternal newborn tend to get people. So definitely
I like
get
maternal newborn. I like OB.
Yeah.
I want to be an OB nurse. I really like it, but I don't like peds.
That's awesome. You're gonna make a great OB nurse. I love that. All right, you guys. I did leave a link in the chat if you want to leave feedback about the presentation. But yeah, for now, and then I do see here you guys asking 29th. Yep, the 29th is care of the newborn, and then on the 1st of May, I do have oncology and palliative care. So those will be my next two. And then you guys will see me after that again every week.
The link? Where's the link, Maria?
Oh, I dropped a link in the chat for you guys to leave feedback. I'll drop it again here. If you guys want to leave feedback about this presentation and if it was good, if it was bad, if you liked it, if you didn't like it, what do you want to say
Where
about
can
it?
we leave it? Because I tried it, but it didn't come. So what I did, I just typed in the chat that I have on there and just, like put the name for the date and everything and the time and my comment there because I couldn't pull it up at all.
Oh, that's so weird. I will let the IT team know that link is acting weird and see what they can do about that. Thank you so much for telling me.
You have to click on those 5-star up there. You have to click on them first and then write the thing in the comments and submit it. That's what I did, and it went.
You say you had to do what?
There is like 5-figure heads, how they call them, emoji thing up there. Yeah. You have to click on them and write your comment and then submit.
Oh, but I
Yes.
just, that's what I'm saying, that when I click onto the link here, that did not come up on my screen no matter what I tried. It just didn't come
Oh,
up.
that's so weird.
Oh,
I wonder if you copy the link and paste it into a different browser, if that might work for you.
That's what I did.
Oh, okay, okay.
It
And it still
works.
didn't work?
Yeah.
So copy the link and then paste it into the NCLEX browser.
Just copy and paste it into any web browser that you have open, like a new tab, or you can open a new window and then paste it in there and press enter, and hopefully that should work for you. But for the most part, you should just be able to click on it and it should open a new window with that page that I'm showing you guys. And then feel free to leave whatever feedback you feel is appropriate.
All
But I know I
right.
my
Thank
videos.
you so much. Bye.
I click on it, but it doesn't. I don't know.
That's so weird. I'm sorry. I'll check in with IT again and see if there's anything wrong with the link, just in case, though. Okay.
Okay.
Thank you so much for letting me know, and thank you guys for being here and for all your support. I am gonna let you guys go and enjoy the rest of your night, so I don't keep you here for too long. But I'm really, really grateful for your feedback. Thank you guys for everything, and I will see you guys in the next webinar. Okay.
All right. Thank you so much.
Have a good
good
night.
night.
Thank you
Bye.
so much.
You did a good
Thank
job.
you. Bye, you guys.
Bye bye.
Bye.